The guest on this podcast episode has no disclosures to declare.
Hello and welcome to the JCO Precision Oncology Article Insights. I'm your host, Jiasen, and today we'll be discussing the JCO Precision Oncology article, Predictive Impact of Tumor Mutational Burden on Real-World Outcomes of First-Line Immune Checkpoint Inhibition in Metastatic Melanoma by Dr. Miles C. Andrews and colleagues. This study was supported by Foundation Medicine, a for-profit company that conducts FDA-regulated molecular diagnostics, including assays used to measure tumor mutation burdens, or TMB as described in this article. Immune checkpoint inhibitor, ICI, has become a cornerstone in the treatment of metastatic melanoma. They work by activating the patient's own immune system, representing a fundamentally different approach from traditional chemotherapy. Several biomarkers have emerged as promising tools to predict ICI therapy response, and TMB is one of the most extensively studied. TMB is defined as the number of somatic mutations per megabase of an interrogated genome sequence. In Keynote 158 study, patients with high TMB showed better response rates and longer progression-free survival compared to those with low TMB, which led to the FDA tumor-agnostic approval of TMB as a biomarker to guide ICI therapy. In this manuscript, Dr. Andrews and colleagues set out to answer an important question: does TMB predict outcome ICI therapy in real-world patients with advanced melanoma? To explore this, they analyzed the identified data from the nationwide Veteran Health Foundation Medicine Clinical Genomic Database, CGDB. To be included, patients needed to have had at least 2 visits to a Veteran Health Clinic and a Foundation Medicine Comprehensive Genomic Profiling report. Eligible patients had received first-line treatment with either monotherapy from nivolumab or pembrolizumab, or dual therapy from the combination of ipilimumab and nivolumab for metastatic melanoma. And they also needed a tissue-based TMB score for either the Foundation 1 or Foundation 1 CDX genomic test. For this study, TMB less than 10 mutations per megabase was considered low TMB. TMB equal and more than 10 mutations per megabase was considered high TMB. And TMB equal and more than 20 mutations per megabase was considered very high TMB. Of the 497 patients in the final cohort, 29% had low TMB, while 71% had high TMB, while 50% with very high TMB. The authors observed that patients with very high TMB were more often male, had a BRAF wild-type tumor, and were more likely to receive anti-PD-1 monotherapy. This group also had tumors more commonly sampled from brain and lung metastases. Patients with high TMB but not very high were more likely to carry the BRAF V600K mutation and were the least likely to have lung metastases. Meanwhile, those with low TMB tended to be younger and had disease limited to non-visceral size. As expected, the presence of ultraviolet mutation signatures, a known driver of melanoma, was strongly associated with TMB. UV signatures were found in just 18% of low TMB group, but in 89% of high TMB and 93% of very high TMB group. High TMB was found to be prognostic of improved real-world PFS and OS in patients receiving both monotherapy and dual immune checkpoint inhibitors, even after adjusting for other established prognostic factors. Interestingly, in the low TMB group, overall survival was likely confounded by the availability of effective second-line target therapy, particularly for BRAF mutant patients. These patients had a better outcome compared to their BRAF wild-type counterparts, likely reflecting a greater reliance on salvage therapy in low TMB patients who derived less benefit from first-line immunotherapy. The author then further examined the ICI outcome using stepwise TMB thresholds, with TMB less than 10 as low, 10 to 19 as high, and equal and more than 20 as very high. For those receiving ICI monotherapy, both PFS and OS were highest in the very high TMB group, followed by the high TMB group and the lowest in the low TMB group. However, in patients treated with dual ICI therapy, the results diverged. While low TMB patients still had the poorest outcomes, those with high TMB mutations within 10 to 19 had better PFS and overall survival than those with very high TMB mutations per megabase more than and equals to 20 group. The authors then conducted exploratory multivariable modeling showing that among very high TMB patients with BRAF mutations, dual ICI therapy was associated with a significant higher hazard ratio compared to monotherapy. They concluded that the dual ICI may not benefit and could even harm patients with very high TMB, whereas those with TMB between 10 and 20 mutations per megabase may get more from the intensified regimen. Importantly, as the author stated in the manuscript, we need to know that in this cohort, very high TMB patients were more likely to have brain metastasis at treatment initiation, be male, and lack BRAF V600E/K mutations. All factors associated with poorer prognosis, and this might partially explain inferior outcomes to dual ICI in very high TMB patients, as patients were not randomly assigned to therapy in this retrospective real-world study. As such, this finding should be interpreted with caution and validated in future studies. In summary, this study showed that in real-world setting, high tumor mutation burden predicts better outcome with immune checkpoint inhibitor therapy in patients with advanced melanoma. Interestingly, the author found that dual ICI therapy may offer no added benefit for patients with very high TMB compared to ICI monotherapy. However, this was a retrospective, non-randomized study, and the cohort were imbalanced for some no-risk factors, which could confound outcomes. As a result, these findings should be interpreted with caution and will need to be validated in future prospective studies. Thank you for tuning into JCO Precision Oncology Article Insights. Don't forget to subscribe and join us next time as we explore more groundbreaking research shaping the future of oncology. Until then, stay informed and stay inspired.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.